Welcome to Primary Care Conversations with Christine and Jeff, providing valuable and engaging pearls of wisdom on a broad range of topics relevant to your practice. Now join your hosts, Dr. Christine Palmay and Dr. Jeffrey Habert, as they guide you through the ever-evolving world of primary care.
Hello, everybody. I am Christine Palmay, and welcome to our podcast. And I am joined with my colleague and most excellent friend, Jeffrey Habert. How you doing?
Hi, nice to see you.
Nice to see you again. So we just had such a wonderful guest, Dr. Poddar, who was introducing obesity, some ethos, changing guidelines, changing perspectives. And this is part 2. And since, Jeff, you are a leading expert in this field, I am just going to bask in the glory of your knowledge.
I don't know about being a leading expert. I mean, I know a little bit about it, but sure.
I'm pretty sure that you'll prove otherwise. But really, we're here to talk about sort of the nuts and bolts, the pharmacotherapy options, practicalities.
I mean, one of the biggest things that Mega just said, and I know you heard it also, and it really, a light bulb lit up, is we're going to talk about the medical treatment of obesity today. And the big point she just made is these drugs, we should not think of them as weight loss drugs. They are drugs to treat a chronic illness. And patients with obesity have often suffered their entire life. And it's not about treating the weight only. It's about treating the pathophysiology. And like she said, it originates in the brain.
And it's hard because we're trying to change medicine and starting a movement, internally, but we're also dealing with media and the Kardashians, where it's just about the aesthetics. It's just about weight loss and nothing else. And so I really took that to heart. And I think, going forward, I'm going to change the way I talk about the different classes.
And the one thing I've learned, first of all, is we need to take a weight just for insurance purposes in any case. But the one thing I've learned over my journey in the last 3-4 years with these experts is you should never give the patient a goal. They want a goal, and their expectation may be they're 250 pounds, they want to get down to 150. And we're not going to talk about a goal, or they're going to say, hey, Jeff, what do I need to be a healthy weight? And I'm going to say, there's different variations of healthy weight. We want you to get to your best weight. And I'll often ask them, what does success look like to you? What do you want to be able to do? And they'll tell you, you know what? I want to be able to run around with my kids or my grandchildren. I want to be able to go for a long walk with my partner without feeling short of breath or being sore. I want to stop snoring at night. Success looks very differently to different people, but we need to think of these drugs as drugs that treat an illness that actually originates in the brain.
Fun.
So let's talk about who qualifies. And qualifies is an interesting term. So the guidelines talk about it. Our Canadian obesity guidelines are among the most well-respected obesity guidelines in the world. I was at a recent obesity conference in Europe, and that's all they talked about were our guidelines. So they really are worldwide respected, which is incredible. So we know anthropometrically, and there's a lot of debate. To qualify for these drugs now, you have to have a BMI over 30, and we know BMI is certainly not the be-all or end-all, or have a BMI over 27 with comorbidities. And I'm saying that more to satisfy our insurers. And Mega made it very clear that different racial populations have different BMIs that may be healthy. And in certain populations, lower BMIs are considered not to be healthy. But standard, I'm just giving a standard, generally we're looking at 27 with comorbidities or 30. So currently in Canada, we have Orlistat, which is a fat blocker. And we're not seeing a lot of people use it anymore because it's a difficult drug to use. And then we have 2 drugs currently indicated to treat obesity and are targeted toward the brain, exactly like Mega said. So we have semaglutide, and people often know it as Wegovy. And we have naltrexone bupropion or Contrave. So those are the 2 current ones. We have one that's imminently going to show up in Canada, known as Mounjaro or Zepbound in the States, or tirzepatide, and that's going to have approval in Canada probably within the next 60 days. And next year, we have some real exciting stuff coming. I mean, we can talk about that if we have time. And
Mhm.
the mechanism of action of all these drugs are really to target those hunger centers in the brain.
So, I mean, I don't really use orlistat. I don't think anybody does. So you're
Right.
really left with the other game players.
Right.
So let's talk. I'm going to throw a case. Male patient, BMI is 32,
Okay.
osteoarthritis,
Yep.
a pick a knee, um, reflux, intense GERD. What are you, okay, I mean, we talked a bit about asking permission and whatnot. So we've done all that.
Or he
And
may have given you implicit permission because he knows you and he says, Christine, you need to help me lose weight. He's given you permission.
okay, so that foundation has been built. Where are you going? What are you starting with? And like, even practicalities, Jeff. How are you writing the prescriptions so you're not getting countless
Well, I mean,
boxes back?
we'll talk on label. So
Hmm.
the on label options for him now would either be Contrave or Wegovy on
Hmm.
label. Off label, we have Ozempic, we have Mounjaro, but let's
Hmm.
talk on label. I will give him the options. I mean, Contrave is a pill. If you look at the clinical trials for Contrave, you're looking at weight loss of, let's say, 7 to 9%. And as little as 5% weight loss will give you metabolic benefits. But so Contrave, it's an oral medication, 7 to 9% weight loss. Whereas we have a drug like semaglutide, Wegovy, where the clinical trials like step one, depending on if you're looking on treatment or intention to treat, 15 to 17% weight loss. So quite different. I'm finding now most people are coming in and they're saying, I want that injection that the Kardashians are taking, or I want Ozempic. And then I have to explain to them that Ozempic is a drug we use to treat diabetes,
Hmm.
semaglutide, and that same drug has been formulated in higher doses to treat patients with obesity.
And can we talk a bit about contraindications? Good.
Yeah, I mean, it's very interesting because there's a lot of social media on these drugs being so dangerous. And in
Hmm.
fact, I think they're probably, I mean, in my career, I'm thinking of three families of drugs that have been the biggest. I think statins, the DOACs, and now the GLP-1s or
Yeah.
GLP-1s GIPs. So contraindications, a personal or family history of medullary carcinoma of the thyroid, a history of idiopathic pancreatitis, would be a contraindication. In my world, there really would be no other
Yeah.
contraindications, and they're safe. I mean, does everyone? So we're talking about GLP-1s now. Sorry. Um, are there people that don't tolerate them? Absolutely. But in most cases, the nausea, the diarrhea, or the constipation are transient and they will eventually go away. And that's why we go very, very slowly with these medications.
Okay, so we have our patient, given permission, you've given him his options, and shockingly, he decides he wants Wegovy,
Right.
but he actually asks for Ozempic, and then
Right.
you have to explain that it's the same drug.
Yeah, I mean, same drug,
But
semaglutide versus semaglutide.
point being that nobody's going to say Wegovy, everybody's going to say Ozempic. So,
Right.
um, how are we starting? How are you writing your prescriptions?
So this is my script. I'm giving them a prescription for a 0.25 milligram pen and a
Hmm.
zero point 0.5 milligram pen. And I'm telling them to take 0.25 milligrams weekly for the first 4 weeks. That's the first pen. Then they switch to the second pen and take 0.5 milligram weekly for another 4 weeks. Ideally, I'd like to give them the first injection in my office to improve adherence. We don't have a lot of samples anymore, so I usually will have them buy it and bring it up and I'll show them how to do it. Or if they don't want to do that, I'll send them a video. The reason we tell them we're going slow are to mitigate those gastrointestinal side effects. And what I don't want to do is I don't want them to rush. They're going to often call me on week 2 and say, "Oh, I felt great with the first shot. Can I go up?" And the answer is no. I really would like you to take time. You've dealt with this chronic illness for your entire life for many, many years, and we can wait an extra month to go up on the dose. I really want to do this slowly. So 0.25 milligrams for a month, then 0.5. So on Wegovy, there's multiple doses of pen. The next dose escalation, if they're feeling well, if they're not feeling well, I tell them to stay back on the dose. The next dose escalation would be 1 milligram. Then if all goes well, we go to 1.6 milligrams. And if all goes well, we go to 2.4 milligrams.
And I certainly in my clinic am saying, look, this drug will probably make you nauseous and constipated. So let's be
right. Especially
proactive.
in the first month.
Yeah.
Certainly. And that's why we tell them to eat smaller meals, less fatty meals. Generally, most of these patients the side effects will go away. But I think a very important point is I counsel them on not going up on the dose if they're not feeling well.
Correct.
There's no harm in staying back for a few weeks or even a month on the lower dose until you adapt to it. I don't want them going up on a drug where they're really not feeling well. The other thing I tell them is you may not lose a ton of weight in the first month, but you will notice that your appetite's going to change. You are going to want to eat less. It's going to be easier to contain your appetite. You're going to feel different. And once again, I do get a baseline weight because I have to give insurance companies a baseline weight and patients want to know. But I focus more on how they're feeling. Yes, I do weigh them. I weigh patients and we hear a lot of obesity experts saying it's about how they feel. But practically speaking, in our practice, we need to know
Of course, yeah.
for them. And they feel better. So they say, you know what? And exactly like Mega said, the loss of weight over time allows them to eat better and exercise. And remember, it's very important that they eat healthy and that they keep moving because that's really important for their heart, for their brain, for other vital organs. So we're always counseling on behavioral change in addition to the drugs. And as Mega said, what these drugs do is they target the appetite control centers in the brain to really mitigate weight regain. And that's why diets don't work. We've all seen patients lose a lot of weight on Atkins or Weight Watchers or Jenny Craig, but the weight always comes back within a few years. And we've seen, everyone knows about that show Biggest Loser, and the graph from the Biggest Loser is incredible. If you look 4 to 5 years in the future, almost every single participant has regained because that's just what the brain does. And we now know that the regain is primarily due to an increase in appetite and an increase in caloric intake. It's not due to metabolic rate. It's not due to energy expenditure. It's due to excess energy intake due to excess appetite.
So inevitably, one of the questions, and then I want to spend a bit of time talking about Contrave too, but how long, Doc? Like, how long am I going to be on this?
It's like, and I never say whole life, I say long term. It's like saying, how long are you going to be on hypertensive medications? And it's long term. We do have data with both drugs now. We have data with all these drugs now showing that if you stop these drugs, weight comes back and you're looking at 50 to 75 weight regain within a couple of years. So if you follow it out, it will come back. This is a chronic illness, so it is a long-term solution.
I think framing it like that is absolutely essential. Like, would you just take away somebody's diabetes drugs because 3 years
or their
is
blood
up?
pressure medication? What happens when you stop those? Your blood pressure goes back up.
So, when the GLP-1s came out, I really thought that Contrave was going to have a nice tombstone and it was just going to be lost. My goodness, was I wrong? And I think, so two questions. Are you stacking? Are, people who have, let's say they're on maximum, either a dosage or tolerable dosage of their GLP-1 of choice, and they come into you, and I've had a few patients saying, look, like, I still crave and I'm still struggling with the cravings. And then what about the patients who you're just prescribing Contrave? Contrave it still has a huge part of my practice.
Right.
And I found that actually surprising.
So first of all, it's oral. Some patients don't want injectable medications. It's come down in price significantly now, so it's attractive to many. We've seen the trials, 7 to 9% weight loss, so it's pretty good. Traditionally, I would give patients a choice they would choose, and some patients still choose Contrave. And I would have stacked, like I was adding Before we had high dose semaglutide or Wegovy, I would add Contrave to low dose semaglutide or Ozempic, used off label, granted.
Mm.
I was adding Contrave, and I still would consider doing that. Now, because we have newer options in tirzepatide or Mounjaro or Wegovy, I'm not stacking as much, I have to be honest. And I'm giving people a choice, and some are still picking Contrave, and it works. And you know what? It's the proper choice for some. So I think you have to individualize the patient you're looking at. The stacking patient has become less popular with the newer drugs. And I mean, for a second, we can even talk about the newer drugs, like, I mean, completely off label for now, tirzepatide.
Mhm.
But tirzepatide has really nice data in the SURMOUNT trials, and they're coming out soon. But you're seeing over 20% weight loss or 23% weight loss with tirzepatide, which is insane, but now we're approaching bariatric surgery type
That's
weight
crazy.
loss.
That is crazy. Wow.
So, I mean, the world is about to change, and even more exciting next year, we're getting an oral medication called orforglipron. Orforglipron is an oral medication, very easy to manufacture, so we anticipate that it won't be overly expensive. And the weight loss with Orfor is 15 to 16% weight loss with a pill that has no food restrictions. So imagine when that comes next year, what that's going to do to the weight loss industry. So many exciting options. The other thing before we end, I want to mention is how incredibly beneficial these drugs are. So we have the SELECT trial with semaglutide that showed significant reduction in cardiovascular events in patients with obesity and cardiovascular disease. You mentioned osteoarthritis. We have a significant trial with semaglutide showing a decrease in pain from osteoarthritis. We have a trial with tirzepatide in patients with sleep apnea where 50%, 50, reduced to mild sleep apnea where they would not require CPAP anymore. We have renal trials with semaglutide. So the world is changing dramatically.
Yeah.
Tirzepatide is about to publish this year a major cardiovascular outcome trial that will be very exciting to see. So once again, these are drugs that target the hunger centers in the brain, but they have so many cardio-renal, arthritic, sleep apnea benefits that are too numerous to go over here. So it's a very exciting world.
It's funny because the indication, if you're saying weight loss, the gifts with purchase, in fact, to a certain extent, completely outweigh, pardon the pun, the actual official indication. I love this talk for so many reasons. Number one, it's always so special to listen to you and learn from you. Your practicalities. Number two, the looking forward to see what's coming down the pipeline. But I think the best thing is during this time, our Canadian guidelines, our global presence. And, it's time to be truly proud about being Canadian. And we're proud to have you as a thought leader, Jeff.
Thank you so much. And that's why it was so great to have Mega as one of the primary co-authors of the guidelines. So honored to have her, and she was great. It's very exciting for us in primary care. Remember, this is a primary care illness, guys. And we talk about that with ADHD and with sleep and with depression. This is something we should be treating. So yes, there are the megas around that will help us with our complex patients, but this is something we need to be comfortable treating in our own practices.
So elbows up, folks.
All right. Thank you, Christine. That was so much fun. And thank you, everyone, for joining us.
Good night, and we'll see you soon.
Good night, everybody.